Hello everyone, in this video we will talk about the congenital anomalies of tracheoesophageal fistula, which is the anomaly of esophagus. In this image, as you can clearly see, I'll show you the normal basic, what is the relationship between the esophagus and the trachea, and moving on we will discuss what will happen in TEF condition, which is an abbreviation for tracheoesophageal fistula. So here this is the upper esophageal sphincter, and this is the lower esophageal sphincter here, and this is trachea. Now what is TEF is an abnormal connection between the esophagus and the trachea. It is basically congenital, but if it is occurring late in life, it was the sequel of the surgical procedures such as laryngectomy. What will be the epidemiology? The predominance in males, common in prematurity, and 50% with associated anomalies. What will be the risk factors? First, pregnancy, trisomy 80 inverse syndrome, and in condition of hydramnios, where there is a lack of fluid during pregnancy. Pathophysiology. Upper part of the esophagus develops from the retropharyngeal segment of the primitive gut, and the lower part from the first part. Now what happens after this is that at 4 to 5 weeks of gestation, a laryngotracheal groove is formed, which divides the foregut into two longitudinal furrows, and this respiratory tract, and then separated from the esophagus. डिफेक्टिव सेपरेशन, अगर इस सेपरेशन में ही डिफेक्ट आ गया, देन देयर विल बी इनकम्प्लीट सेप्टम, और ड्यू टू इनकम्प्लीट फ्यूजन ऑफ द ट्रैकियल folds result in the fistula formation between the trachea and the esophagus. Now showing here will be, this is the trachea dividing for both the lungs, and we will showing you the connection, the anomalies of the esophagus. This is the blind end. Now it is having 4 types. How it is related in the fistula? As you can see in the type 1, both the ends are blind. In type 2, the ends of the esophagus, one end, upper end basically is having fistula with the trachea. The third part, type 3, is having lower end fistula, and in type 4 both ends fistula formation. So now clinical features. What would be the clinical features of the TEF in infants? Excessive salivation, constant drooling of saliva from the mouth, violent response during feeding, 3 C's, that is coughing, choking, and sinuses. Abdominal distension is found in type 2, 3, and 4, and there is aspiration pneumonia and GERD-like symptoms. Investigation: in case if it is prenatal, we will do ultrasonography, fetal MRIs, confirmatory test. In postnatal, we have X-ray, bronchoscopy, and NG tube insertion, which will be unable to cross because due to resistance. What will be the management? First, pre-operative management, we will maintain the position of the infant, decompression of upper pouch, IV fluids, and antibiotics are given. Surgery is the only treatment for TEF, where there is a thoracotomy, thoracoscopy, and stage 1 surgery. TEF is ligated and gastrostomy is done. Stage 2, both ends are anastomosed with each other, and post-operative we will maintain the oxygen, provide oxygen if needed, analgesics if required. Thank you.